esophagus, long questions mostly are on the anatomy of esophagus with benign diseases. CO esophagus as long questions is extremely rare. Maybe just investigations like giving a case scenario and telling you to discuss about it. Mostly like that. Okay. So esophagus is everyone knows it's a muscular structure. I need to go through the anatomy once more? The basic anatomy. So it's basically a muscular pipe, right? It starts from C6. Okay. So that's the vertebral level and mucosal level. From the cryopharynx, right? Till lower border. What is the level of the esophageal lower esophageal sphincter? It's T11. So C6 to T11. So what is the total length of the esophagus? What is the length of the esophagus? 25 centimeter. There are uttor dichi sir pichon dike boshe লুকিয়ে সামনে এসে বস. So it can be interactive. Okay, so 25 centimeters of a tube. Okay. So how much is cryopharynx from the incisor teeth? What is the distance? 15 centimeters. So total length from incisor to your upper lower end of the esophagus is 40 centimeters. Right? So 15 centimeters is the oral cavity pharynx part and the rest of the 25 centimeters is the esophagus. So how many layers in the esophageal wall? 4 layers, okay? So innermost is the mucosal layer. Then we have the submucosal layer. Then there is the muscular layer. So muscular layer is again has circular and longitudinal muscles. Okay, and lastly there is the fibrous layer, which is a loose capsular layer. So the strongest layer of the esophagus is the mucosal layer. In some books also it's mentioned the submucosa is the strongest layer, but normally for all we say that the mucosal layer is the strongest layer. So what is the function of esophagus? Obviously helps in swallowing or channeling the food from mouth to the digestive apparatus. So what are the phases of swallowing? Firstly we have the buccal phase or the oral phase, right? So what happens in the oral phase? What happens? What are the steps in the oral phase? So when we are taking food into the mouth, the first thing that happens is we start chewing, right? We chewing or make a bolus. The idea is to make the food, whatever food, it can be chicken, mutton, whatever you want, but we have to make it a bolus to help us in swallowing. So that is done by your teeth, the tongue, and the buccinator muscles or the muscles of the face, the cheek. Okay, so all this together helps us, along with the saliva, it helps us making a food bolus. And then when we feel like it's soft enough that we can swallow it, we start the process of swallowing. So the thing that happens when we start swallowing is that our tongue, the tongue goes up and touches the palate, and we push the food bolus posteriorly. Right. So the tongue touching the palate is the most important part of the oral phase of swallowing. Okay, because once the food reaches the pharynx, okay, when it goes posteriorly, it reaches the pharynx, right? So that starts the pharyngeal phase. right? The pharyngeal phase has two main components. Have you ever seen a diphtheria patient? Anyone? Or any patient having a nasal regurgitation? Bulbar palsy patient or something like that, palatal palsy patient. Okay. So the first thing that happens is the nasopharyngeal closure. So the palate, the soft palate, it goes ups, and along the passavans ridge, it closes the nose from the mouth. Right. So the palate is like this. It goes up and touches the posterior pharyngeal wall, so that the nose and the mouth are separate. That's the reason we don't have a nasal regurgitation of food when we swallow. Okay, otherwise it's a single cavity. Then the pharynx opens up. Then there is closure of the larynx. So three main steps. Okay, closure of the nasopharynx, pharyngeal closure, and the laryngeal closure. So how does the larynx close? What is the most important structure in closure of larynx? Epiglottis. Very good. So epiglottis falls back. Actually, epiglottis is not the main structure that prevents aspiration. The main structure is the false cords. So the A folds and the false cord, they form the most rigid barrier to stop the food from entering the larynx. But epiglottis forms a cover over them. That's why we always mention epiglottis as the part which forms the closure. But even if some person has some issues with these epiglottis, say epiglottic surgery or something, he may experience aspiration initially, but later on he gradually recovers because the A folds false cause they take over. Okay, they're much more adaptive than the epiglottis. Okay, so now the food has entered the esophageal phase. It has reached the cricopharynx. So if you see cricopharynx, it's basically a sphincter, right? It's a sphincter. So there are two physiological sphincters in the esophagus. One is the upper esophageal sphincter and one is the lower esophageal sphincter. Right? So there is the resting tone of the muscles are high in these two regions, the sphincters. Okay. So when we are dealing with the upper esophageal sphincter, the length of the sphincter is around 3 centimeters to 5 centimeters. So this say this is the esophagus. Okay, for a length of 3 to 5 centimeter, there is some physiological increased tone in the muscles. Okay, and again lower down in the lower esophageal sphincter, just before the stomach, there is an area of higher pressure. So this we have found out by, so there is no anatomical change. If you look at it anatomically, there is no difference in the format of muscles or anything. Okay, so it's a physiological sphincters. Okay, so increased pressure in these two areas, which causes narrowing of these two areas. So this is a cricopharyngeal opening, cricopharyngeal sphincter, and this is the lower esophageal sphincter or LES. So what does this do? These sphincters help in preventing regurgitation of fluid upwards or food upwards. Right? And this cricopharyngeal sphincter actually also helps in preventing anything to go inside the esophagus which it doesn't want. Right? So main function of LES, the lower esophageal sphincter, is prevention of regurgitation. But cricopharyngeal sphincter is working both ways. It prevents something from going in or it prevents something from coming out as well. Right? So both ways it works. So what Okay, so nerve supply, tell me. So it's an autonomic nervous system, obviously. Sympathetic, parasympathetic supply. Parasympathetic, what is the nerve? Vagus. It's always vagus. Some branch of the vagus somewhere. So if you say vagus, you're always safe, right? And sympathetic is from the sympathetic trunk. Obviously, it's the neck. So sympathetic comes from sympathetic term, trunk. Nothing more in swallowing physiology. Lymphatic drainage, obviously, we all know. It's cervical, thoracic, mediastinal lymph nodes that we drain into. So, coming to the diseases of the esophagus. Okay. What is the commonest disease of esophagus you guys have seen in the OPD? GERD. Very, very good. Who is this? So, GERD is the commonest disease of the esophagus. Well, it's a disease or not? It's not a disease. And what is globus? Okay. So I just was going through your book, Thingra. They have done it. It's changed over years, so they have edited it. So now it's like they have divided into acute and chronic disorders, right? So what are the acute conditions of the esophagus? First is obviously an infection or inflammation. What's that called? That's an itis, the esophagitis. Any cause of esophagitis. So what are the commonest causes of esophagitis? So see, it's a muscular tube, right? So unlikely to catch any infection like that. So the commonest cause is some kind of trauma that's causing an inflammation. That can be anything. That can be acid burn or any corrosive agents going in. Okay. So commonest causes acid or corrosive agents causing inflammation of the esophagus. So that can be anywhere from the level of the cricopharynx to the lower esophageal sphincter. Okay. You have seen an acid patient, acid injury patient. If you get to see once, always carefully examine the patient. You'll get to learn quite a few things. Okay. So esophagitis usually presents. How does it present? Tell me, inflammation in the body, how will it present? Pain, dysphagia, commonest symptoms. Okay, so it's all in in a system. You should not fumble on these things. Very, very common things. So, pain, dysphagia, commonest causes. Oh, another important cause is of esophagitis is ingestion of any foreign body. So, what is the? We have seen many esophagitis in children because of ingestion of some corrosive foreign bodies. No, not coin. Coin will not cause esophagitis. Batteries, yeah, very common. Batteries which are coin batteries. Okay, the children love to swallow that. Okay, so if it goes, this passes through the LES, it's fine. If it doesn't, if it stays back there for 2 to 3 days, it will definitely cause esophagitis, corrosion, and sometimes even perforation of esophagus. So the second topic is perforation of esophagus. You know what is the commonest cause of esophageal perforation? Iatrogenic, very good. So iatrogenic is actually the commonest cause of esophageal perforation. The corrosive agents and iatrogenic causes. These are the two main causes of esophageal perforation. So once we breach through the mucosal layer or cause any damage to the mucosal layer during esophagoscopy, we are always very worried. This patient may develop esophagitis. Okay, normally in other parts of the body, we don't care. Okay, there is some soft tissues around, so it will heal up. Mucosa healing is very quick, usually very fast. But in case of esophagus, we are very much worried. Because once the mucosa is breached, it can easily cross the other layers, the infection, and cause a diffuse esophagitis. and can cause other complications as well. Because esophageal tube which lies in the mediastinum. So any infection of the esophagus can easily spread to the mediastinum, causing mediastinitis. Okay, so it's a dreadful scenario. So perforation of the esophagus causes iatrogenic and acid or corrosive agents, and obviously foreign bodies perforating from the esophagus to going outside. Riles tube insertion. I have seen one patient. I'll remember for the rest of my life. One patient, guided esophagoscopy done by a gastroenterologist, put it in. So once it crossed the cryopharynx, he put the scope out. It will easily go in. It went in. Gargling sound was also there, like not gargling exactly. He got some sound to confirm the position. Then when the patient started eating, he was complaining of severe pain. The patient was complaining of severe pain. So these nurses didn't understand this, started feeding. Because normally we always confirm the position of a rice tube with an X-ray. But since it was guided, we did not. Started eating, pain worsened, developed fever. Then another X-ray was done. Found the rice tube is not in the midline. It has come in the midline initially and then has gone laterally. Then again esophagoscopy and things were done. It was perforated the esophagus, has gone outside in the mediastinum. That's a very dreadful scenario. So this patient must have had any weakness in the esophageal wall probably. Normally rice tube will not perforate, it's not sharp. But sharp foreign bodies like dentures, which has wires. Okay, safety pin. I have a publication, removal of a safety pin from our kit. So they usually open up and can cause perforation. Okay. So then, what is the next? So what is the treatment when you have a patient with a perforation? First is obviously stabilization of the vitals. You start IV fluids completely NPO, nothing per mouth. Okay, you start IV fluids and along with it some nutrition because you cannot give orally, so parenteral nutrition is required. Then you start steroids. Why? To reduce the inflammation. So usually IV steroids like methyl or anything depends on how much the body weight of the patient is. It's 1 to 2 kgs per 2 mgs per kg of body weight. We usually start IV and gradually taper it over 4 to 6 weeks, so that esophagitis can be controlled and there is no development of strictures. So early use of steroids also help in reducing the incidence of strictures. And then comes IV antibiotics. Obviously, we have to be very liberal about IV antibiotics in esophagitis. Okay, because once the patient develops mediastinitis, it becomes difficult to treat. Till the level of esophagitis, it's still okay. Okay, and other supportive medications like analgesics. Obviously, if the patient needs any other support for the vitals, go ahead. That's all. So normally what we do is we do check esophagoscopies later. So once the steroid courses are complete and the patient is in the healing phase, we do check esophagoscopies every 4 to 6 weeks to see if there is complete healing. So these esophagoscopies are not rigid esophagoscopies; these are flexible esophagoscopies, like upper GI endoscopies. Okay, because these are for visualization only. So no rigid esophagoscopies here. These are usually done by the gastroenterologists. Sometimes we also do, but depends. This is to check whether the perforation has healed or not. Okay. So after that, another very common disease is this benign strictures of the esophagus. So again, the causes are almost the same: corrosive agents, inhalation of ingestion of foreign bodies. Okay, that can cause trauma to the wall of the esophagus, can cause strictures. Okay. burns, ulcerations, any disease that can cause ulcerations of the esophagus, esophagitis can result in strictures later on. So stricture is something that's a healing process. Like we have seen hypertrophic scars. You've seen hypertrophic scars, obviously you've seen. Everyone, many of you guys probably have. Okay, so stricture is more of like a hypertrophic scar. So it has not healed the way it should. There's some secondary healing because of some damage to the esophageal wall, and the secondary healing causes narrowing of the lumen of the esophagus. That can cause strictures. So strictures can be benign strictures or it can be malignant strictures which are caused by CA malignancies. That can be primary malignancies of the esophagus or any other malignancy from joining areas spreading into the esophagus. Okay. So now comes the motility disorders. Tell me the names of the motility disorders. Achalasia Cardia, okay. One. Then the spasms. Sencus diverticulum is not a disease of the esophagus. It's a pharyngeal pouch, it's disease of the pharynx. Motility disorders, I'm saying. So there are some issues with the motility. So what is the normal motility? Normal peristalsis, right? So we have normal peristalsis, normal motility of the esophagus. So that's a synchronized movement of the muscles of the esophagus to push the food bolus from the cryopharyngeal level to the esophagus. Right? So that's the way it should go. But sometimes we have some incoordination or altered movements in the esophagus which can cause issues with swallowing, dysphagia, or other problems with swallowing. So, what are the commonest motility disorders? Achalasia Cardia is not very common, though. The commonest involves the esophageal spasms. Okay, the cryopharyngeal spasm or the diffuse esophageal spasm. We gave an X-ray during the last exam. Nutcracker esophagus. Have you guys seen that? You can Google it. So it's a diffuse esophageal spasm. What happens is, say this is the esophagus. So ideally this wave should come like this, right? It should gradually push the food in. But what happens is instead there is this area of narrowing, then this area of narrowing, then this area of narrowing. So it's not coordinated. So what we end up having is this kind of esophagus. It's called a corkscrew esophagus. Okay, a roseberry esophagus. So this is a diffuse esophageal spasm. So we do not know why it happens. So it's some issues related with the coordination of the autonomic nervous system. Okay, causing some irregular spasms of the esophagus. So what does the patient present with? Obviously, once again dysphagia, pain occasionally. Okay, and the dysphagia can be very severe, and dysphagia is mostly triggered by eating. When the patient is just sitting idly, it's fine. When he starts sitting, he starts having this discomfort and difficulty in swallowing, and it feels sometimes it's so severe that patient can't even swallow liquids. Okay. Cryopharyngeal spasm is something like when the cryopharynx doesn't open up. So when the food goes from pharyngeal phase to the esophageal phase, the upper esophageal sphincter, there's a cryopharyngeal sphincter should open up, right? That's how you should allow the food to enter the esophagus. So that's a normal coordinated movement. So sometimes what happens is this esophageal upper esophageal sphincter, the cryopharyngeal sphincter, it does not open up properly. Okay, that's most commonly caused by some neural incoordination, and it can cause severe dysphagia. This is also triggered by food. Nutcracker esophagus is a very uncommon thing. It's a high amplitude, small fluctuations in the muscles of the esophagus. Normally, if you go to a diagnostic test or you do an esophagoscopy, you won't find anything. It's absolutely normal. But there is some abnormal spasms of the esophagus throughout. That's called a nutcracker esophagus. So, Achalasia Cardia. Okay. So, what is Achalasia Cardia? Tell me, you were telling. Only lower esophageal sphincter too. Yes. So there is the lower part of the esophagus, that is the say this part. The lower esophagus, like we had the cryopharyngeal spasm in the upper part of the esophagus. So similarly, the lower part of esophagus, there is no peristaltic movement. Okay. So what will happen if there is no peristaltic movement? There can be dilatation of this part of the esophagus, and then narrowing of the lower part of the esophagus to the stomach. Right. So it's achalasia. So there is no movement, no peristaltic movement of the lower part of the esophagus. So how do we treat that? So it's narrowed, right? So what do we do to treat it? And this is narrowed. It's always narrowed. It's not like it is opening up, narrowing. There's no peristalsis. It's fixed. So either we need to do serial dilatations. Okay, we need to do esophagoscopies and dilate the lower esophageal sphincter or the lower esophageal area, which is just gone into. So short notes you can have from Achalasia Cardia. And one thing typical of Achalasia Cardia is they'll have dysphagia more to liquids than solids. Okay, other spasms you may have dysphagia more to solids than liquids because there is problem with the peristalsis. But here there is a complete stoppage of peristalsis. Okay, so we will not have any movement. How do we diagnose Achalasia Cardia? Okay, before that, barium esophagus, an X-ray barium esophagus. So that will, what sign is called? Rat tail or bird beak appearance. Okay, so that is very typical of like that. So there is a dilatation of the lower part of the esophagus followed by a thin narrow tail coming down. Okay, this will be given in your X-rays. You have seen, I think you have seen the X-rays, right? So this is given in the X-rays. So treatment, like I said, it's usually dilatation and sometimes even we need stenting. But what happens is, when you stent the lower sphincter, the sphincter doesn't close. Like you have kept a stent over there, so it's always open. So the patient will have a lot of reflux issues. So we prefer to do dilatation initially rather than stenting. Next comes the most common cause, that's the gastroesophageal reflux disease. It's called the GERD. So, what is a GERD? So you see, the stomach is meant to handle acid, right? pH of the stomach is low. The wall of the stomach is made in such a way that it can handle corrosives, it can handle acid. Right? Because pH is low in stomach, there is production of hydrochloric acid. But if this acidic food content comes upwards, the esophagus is not meant to handle acid. It's not made like that. Okay. So what happens is when this acid acidic food content comes up into the esophagus, it can cause issues. It can cause irritation. It can cause inflammation, and it can cause dysphagia. Because once there is inflammation, there is edema. Okay. So see, GRD is a very broad, wide term. So any reflux, as said, with low pH in the lower part of the esophagus, that is reflux of acidic content from the stomach to the esophagus, is called gastroesophageal reflux. But that has to be documented. This is the difference between GERD and globus. Patients with globus will have symptoms, similar symptoms like a foreign body sensation in the throat, dysphagia, these things, okay? But when you do a pH or a manometric study, you'll see that it's normal. While in GERD, if you do a pH study, you'll see that no, the lower esophageal pH is dropped significantly. So it's very acidic. That means there is some kind of reflux going on. If we compare globus and GERD, because I am telling you this because these two are very common scenarios in the OPD. A lot of patient comes with this foreign body sensation. I think you guys have also seen who has done come to my OPD. They've also seen. So this patients come with a foreign body sensation in the throat and upper part of the chest. And they usually say that whenever we eat something, this increases and causes problem because the stomach is loaded. So there is easy reflux of the food content into the esophagus. Right? So what do we do? How do we diagnose? Okay, manometry, yeah. Because there is decreased tone of the lower esophageal sphincter, causing dilatation of the sphincter and reflux of the food material into the esophagus. And then we do the pH study. So we can do combined. We can do a combined pH and manometric study. So there is usually a probe that is kept at the lower esophageal sphincter for 24 hours. Okay, so it's called 24 hours pH monitoring. So we see the cycle of pH changes throughout the day when the patient is eating or when the patient is in empty stomach. How this acid environment, how the environment is there all through the day, all through these 24 hours. So that helps us understand whether this is just a one-time thing or it is going on every time. Whenever the patient is eating, food is having. So every time and causing symptoms. There is a low pH and the low pressure on the manometry. 24 hours manometry. That signifies that this is a GERD. Okay. Then comes hiatus hernia. I'm coming to the treatment of GERD later on. First, let me discuss hiatus hernia because hiatus hernia is one of the commonest cause of GERD. Okay. So, what is a hiatus hernia? So, there is some issue with the diaphragmatic opening of the esophageal opening of the diaphragm. Right. So, it can be either the entire thing going up or a part of it. Like, see, so this is the stomach. Okay. So, this is the esophageal sphincter. That's the normal. So, sometimes this may go up through this opening. So the entire thing along the esophagus, along the vertical line of the esophagus may go up inside. This is called a, what's it called? It's called a rolling hiatus hernia. And what is the other one? Where a part of the stomach has gone in. It's called a sliding, or the other way around. So one is a rolling and other one is a sliding hiatus hernia. Yeah, they have mentioned the sliding and the paraesophageal. So this is the sliding hiatus hernia, and this is the paraesophageal. It's also called the rolling hiatus hernia. At the part of the stomach along the by the side of the esophagus goes into the thorax. So this is caused by the increased intra-abdominal pressure, okay, and laxity of the muscles of the diaphragmatic opening. So what will happen? There will be gastric contents inside the esophagus. Okay, either way, there will be gastric contents inside the esophagus, and the patient will have symptoms of heartburn. Right? So it's almost the same symptoms as of a gastroesophageal reflux disease. Right? So how will you identify? So that's why in gastroesophageal reflux disease we normally start treatment with medications. But if the patient is not responding to conventional medications over 2 to 3 weeks and still having severe symptoms, then we have to do a upper GI endoscopy to visualize. Okay, that is very, very important. We have to do a upper GI endoscopy. So once we have diagnosed a case as a GERD, what treatment will we start? So the first is lifestyle modification. We'll tell the patient to come to a proper disciplined lifestyle. What does that include? So three things you never forget. One is early dinner. Okay. Early dinner is very important. If we eat late at night, it will cause issues with reflux because the stomach will be fully loaded. What is the normal gastric emptying time? Is 1 to 4 hours. Okay, up to 4 hours. So if we give 2.5 hours or around 3 hours post meal before we go to bed, that will help is most of the emptying of the esophagus will be done, stomach will be done by that time. So chance of reflux will decrease. Okay. And the second thing that we tell the patient always is to stay upright, not to lie down immediately after a meal. There are a lot of patients who come and say, okay, doc, I don't usually go to sleep very early, but I lie down and work in my computer. So we always tell the patient, no, don't lie down, sit in a chair proper, or you can walk around, do whatever you want, you can watch TV, do whatever you want, but don't lie down. Okay? These are the two most important things. And then, inclination of the bed. We tell the patient to have the bed inclined so that the head end is slightly up. The same thing that we tell a patient with a Rayleigh tube. Any patient with a Rayleigh tube, we always say propped up position. We always say why? Because the tube is going through the ileus, so the ileus is open always. So if you don't prop the patient up, you'll have aspirations. Because the ileus is open, the food will come from the stomach to the esophagus. Okay. Stopping of smoking or other, irritants that can cause smoking, alcohol can cause increase in chances of the gastroesophageal reflux disease. So after lifestyle modifications, then comes the medications. What medications do we use? Always start with H2 receptor antagonists. Okay. Don't go directly to PPI. Though we use PPI directly, we don't wait for H2 antagonist to work. We start with PPI for exam. Always start with H2 antagonists. Okay. Then comes proton pump inhibitors. And nowadays we have more modern drugs. So with that, if the patient responds in 2 to 3 weeks, it's fine. Otherwise, we'll go ahead with an upper GI endoscopy. Okay, and we'll assess the condition. There can be some other disease that we are missing. There can be a growth in the esophagus, or there can be a polyp in the esophagus. It's causing problems in swallowing. Another disease is another benign disorder that comes as a short note is a Plummer-Vinson syndrome or Patterson-Kelly-Brown syndrome. So what is that? Not esophageal wave, it's cryopharyngeal wave. Don't say esophageal wave. The entire esophagus is not waved, only the cricopharynx. So there is waving of the post-cricoid area. Okay, and what are the combination of symptoms? Signs? Anemia. What type of anemia? Iron deficiency anemia. Then glossitis, angular stomatitis. Then what happens with the nails? Koilonychia. What's it called? What is the thing? Spoon-shaped nails. Okay, koilonychia, and along with that, dysphagia. Okay, so all of this together. So it's called a Plummer-Vinson syndrome. So why are we worried about Plummer-Vinson syndrome? Because it's a pre-malignant condition. There's up to 5% chance of a Plummer-Vinson syndrome converting to an invasive malignancy. Okay, so that's why Plummer-Vinson syndrome, if you're diagnose a patient to have post-cricoid waves, please look for the other signs. If it's a Plummer-Vinson syndrome, follow up the patient. Treat the anemia, okay, and treat other deficiencies like the vitamin deficiencies. Patients will have vitamin deficiencies, vitamin B deficiencies, vitamin C deficiencies. So treat the deficiencies, follow up the patient, start on proton pump inhibitors and other medications to decrease the reflux and improve the dysphagia. Okay. And you can also do dilatation of the cricoid waves, okay, to open up the cricopharynx better, and monitoring, nothing else. Then comes the last disease and the most important disease. What is that? The CA esophagus, right? So what are the two types of cancers that happen in the esophagus? What are the pathologies? All types of cancers, squamous cell cancers and adenocancers. So squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma can happen anywhere, but adenocarcinoma is usually limited to the lower part. So most of the cancers in the upper part of the esophagus that we normally face, most commonly are squamous cancers. Almost all of them. Sometimes we face adenocancers in the lower part of the esophagus. Okay. So how does this patient present? Dysphagia. So I've seen many patients, of CA esophagus who has come with symptoms of GERD. So because they have symptoms of GERD, they come to a ENT specialist. Okay, we do a laryngoscopy. We see nothing is there. So then we order them to do a upper GI endoscopy. We start medications. We wait for 2 weeks. Patient not improving. We go for an upper GI endoscopy, and that's when it is diagnosed to have some growth in the esophagus. Okay. So now the patient has come to you with dysphagia, has been diagnosed to have a growth in the esophagus. So what will you do? What's your next step? Biopsy. Biopsy, how will you do a biopsy? So now we always do a endoscopy guided biopsy. Obviously, we do an endoscopy and take a bunch of tissue from it. Say the endoscopy bioidal biopsy is a squamous cell carcinoma. Now, how will you treat it? See, esophagus is very difficult to treat. C. esophagus is quite difficult to treat. Why? There's a lot of important structures around. You have the bronchus, you have the carotids, you have all the major vessels and the vital structures, the lungs, everything in there. Okay. So disease in the lowermost part of the esophagus is easier to treat. Why? Because you can approach to the abdomen. You understand what I'm saying? In the lowermost part of the esophagus, if there is some disease, you can always do a surgery with the wide margins or removal of all the adjoining nodes. But if it is in the upper part of the esophagus, it's difficult to treat because we sometimes do surgeries. It's mostly done by the thoracic surgeons or the gastro surgeons, not by head and neck surgeons. So what they do is they do something called a gastric pull-up. So say this is the esophagus, this is the stomach. Okay. So the bowel is lax, right? Before the vasectomy starts. So they have removed this part of the esophagus. So they mobilize the stomach, widen this sphincter, and take the stomach up and connect this with this. It's called a gastric pull-up. Okay? Or sometimes they do something called a jejunal loop. The part of the jejunum they resect. Do a primary anastomosis here. Take the loop, place it here. But these patients do have dysphagia because a jejunal loop or a gastric pull-up will not have the normal peristaltic movements that because peristalsis is very important in feeding. Okay. So presentation will be dysphagia, pain. What are the symptoms the patients can have? What is the Warshaw's node? Which side? Left. Why does it happen? Lymphatic spread. So what are the spreads? How can the disease spread? First is obviously local spread. Okay, so disease is involving the esophagus, say lower part of the esophagus or the upper part of the esophagus. It can involve the adjoining structures. Right? It can involve the bronchus, or it can involve the trachea, or it can encase the blood vessels. Okay? And all the mediastinal tissues. Second is lymphatic spread. Lymphatic spread is to all the adjoining lymph nodes initially. That's mostly the mediastinal lymph nodes for esophagus. And then comes if it goes lower down, it can involve the paraortic nodes as well. Okay, and this is important, the Warshaw's node, because the Warshaw's node, because it is caused. Why is it caused? Why there is left supraclavicular node enlargement? Someone tell me. Huh? Direct spread to supraclavicular lesion from lower esophagus or stomach or any GI structure. It's a GI cancers will have that, right? Right? Have you heard of chyle duct? Cistern, shiny, chyle duct. You have heard of it, right? So it goes up. It goes up like this. So it goes up like this, then crosses the esophagus and comes to the left side, where it drains it comes up like this in the neck and drains at the junction of the subclavian vein and the IJV. Okay. So if there is tumor seeds in there, okay. So if this cistern chyli or the chyle duct is invaded by the tumor, so the lymphatic drainage will not occur. Okay, and there will be backflow into this supraclavicular lymph node, causing its enlargement or metastasis. So metastatic left supraclavicular lymph node in case of abdominal malignancies is called the Warpose node. Okay, it's a telltale sign of some abdominal disease. Okay, so in mid-esophagus, like I said, the treatment of choice is mostly radiotherapy and chemotherapy. Okay, because surgery is difficult and often unrewarding because CA esophagus has a bad prognosis. So, what are the causes of CA esophagus? Why does it happen? It can either come from a benign stricture or some previous acid burn or anything that's causing the stricture that can later convert into a malignant ulcer. Or it can be caused by substance abuse like smoking, alcohol. Okay, and sometimes some people say that smoked food can also cause like stomach cancers, stomach poison. This is the commonest in China, commonest in Japan. Sorry. Okay, where they eat a lot of smoked food. Okay, the Indian scenario is mostly due to smoking alcohol, gutkha, khaini, and all kinds of tobacco, most commonly. Okay, what are the other what investigations would you do in case of a C. esophagus if you are suspecting a C. esophagus? Biopsy তো করলাম biopsy করার আগে তুই মানে when the patient has come to you in the OPD, you have done upper laryngoscopy, has not found anything. Before sending the patient, upper GI endoscopy is something that you need to do under anesthesia, right? So before putting the patient into anesthesia, what test you think you should do? For any esophagus, and nasal esophagus, we go for a barium swallow esophagus, right? So what will it show? Shouldering. Oh. So it's called an irregular filling defect. It can be shouldering. It's an irregular filling defect because when it's a malignancy, it is not a globular smooth wall structure. The surface is irregular. So treat. We'll do and then the further investigations. What we can do is do the scans. Okay, the CT scans or the MRI scans to see the extent of the disease, and based on that, we treat the patient. Okay, post-treatment patients have complications like strictures and radiotherapy, and we keep the patients on 3 monthly follow-ups to see if the patient is developing any issues.